So we come right here to the Wharen lecture. Jennifer, we are excited to have you, Dr. Moliterno. It's a great pleasure. I'm going to show you, and I'm going to have Dr. Wharen just say a few words. These are the speakers. We started, you know, this came out of recognition of the tremendous amount of work that Bob put on this department for over 3 decades. And one of his tremendous mentors was Dr. Loss. And we felt when we established this lecture, we couldn't have one last year. We were in the middle of chaos around the world, as Bob said at the beginning. Bob, you want to say a couple of words about the speakers that we had and the significance of what Mayo, Florida meant to Mayo Enterprise in general, please?
Yes, good morning, everyone. In a very short year, there's a lot of new faces, and I look forward to meeting all of you when we have a chance to get back to live conferences. We've been very honored to have some tremendous individuals who have shared their insight with us and shared their expertise to our department. Dr. Moliterno, thank you for sharing your expertise with us today. And when you get a chance, please say hello to Joe Pietmeyer for me.
Beautiful. Thank you, Bob. Always amazing. It's so great to have you. I know you're 2 hours early, but we're excited. You can see the speakers, Jennifer. We're so excited to have you. Our team member looked at some of your qualifications, tremendous. And that's what I was asking about your time at UF, you know, as you spend time there as well before going to Yale, and then of course staying there as a faculty with tremendous amount of accomplishments and a very few short years already climbing, you know, the rankings in academic neurosurgery at a tremendous institution with such a great history, all the way from Cushing to the people that are currently working there with Dr. Gunnell, as Dr. Pietmeyer, so many other giants in the field. Tremendous accomplishments, you can see, of course, there at University of Florida, all the way to Yale, and we're very, very proud. These are some of the ways in which Dr. Moliterno has been changing the world. We looked at it, a tremendous amount of contributions to science in general. You serve not only as a role model in science, but also as a neurosurgeon, as someone who has a vision that is larger than life. And to see you at the meetings with your son and to see you with your family, it gives me a tremendous amount of pleasure in giving your talks, and somehow you just are able to get it all done. And we're very, very proud of the things that you're doing and the accomplishments, tremendous amount of publications. And you can actually already see these are some of the relevance right here, but the H index, you know, really climbing up, as you can see for the past few years, really taking a tremendous turn, of course. And what you're doing, it means so much to the world. And of course, your work in genomics is legendary. So we are excited. I'm gonna stop right here. And let me see if I stop sharing right here, Jennifer, so that way we can allow you to share your counsel. And we give you about, as I said, about 30 minutes, and then we're gonna be meeting with you throughout the day. We're excited to have you. Thank you for dedicating your morning to us. It just means so much. I know you're busy, everybody's busy, and for you to dedicate your morning for the fellows, the residents, and everybody, we thank you from the bottom of our heart. Please take it away.
Thank you from the bottom of my heart. This is an incredible, you can hear me okay?
Yes, perfect.
It's an incredible honor and privilege. And first, to start by thanking you for the invitation, thanking Dr. Wharen in honor of his name. What an incredible privilege and honor. And really what an incredible program and place you have. And I really am going to invite myself to come in person next year. Because I really cannot wait to see all the incredible things that you're doing. So thank you from the bottom of my heart. I will share my screen. And I'm on my fellow's laptop because I had a little bit of a glitch with my computer. But you can see?
We can see it perfectly, you know, and we think, I hope you don't mind also that we're recording, and actually we archive this. So I hope you don't mind.
Of course not. Thank you so much. And then let's see. Okay, that should work. All right, so thank you so much again. Really an honor and a privilege to be here. So thank you. I look forward to sharing the work that we've been doing the last few years, specifically on the clinical implications of the genomics of meningiomas. I only have one disclosure, which is not relevant to this talk. So meningiomas are a fascinating tumor, particularly to me and my practice, in the sense that not all meningiomas play by the rules as they're supposed to behave and as you would expect. And so I have found in my clinical practice as a primary brain tumor surgeon, is there really a such thing as a benign meningioma? The other questions that we've been asking is, how does the underlying tumor biology affect the clinical behavior? How can this influence our management of meningiomas? And really the big question is, why do some low-grade tumors behave more like high-grade meningiomas? This is a patient of mine who initially was managed by another neurosurgeon in 2015. I don't have that initial scan, but he had a convexity meningioma at the time, similar to what you can see on the 2017 scan, underwent a gross total resection. He was told it was a benign grade 1 meningioma, and it came back, as you can see, in 2017. At that point, he wasn't referred to me just yet. He sought other opinions in New York. He was close to the New York border, and he ended up undergoing radiosurgery, and you can see a little bit of edema there as well. So this now is in 2019. After radiosurgery in 2017, he presents to me with intractable seizures, wheelchair bound, weakness on his left side. So I took him to surgery, gross total resection, his weakness improved, he did beautifully, and his seizures went away. But the question that I had was, could this have been better predicted and managed differently the first time? A similar patient, 58 years old, I don't have his initial scan, but in 2014 underwent a bifrontal cranie. I'm not sure if my mouse is projecting or not, hopefully it is, but you can see the defect that he has from that post-op cranie defect. And he was told as well that this was a grade 1 meningioma. He had a great extent of resection, and he really could follow up as needed. It came back in 2016. The original neurosurgeon called me, asked me to manage him. I did, and of course, because of the huge defect that he had after the gross total resection, had my colleagues from plastics and ENT help reconstruct him, and that's some of his abdominal muscle. But the question is, could this have been diagnosed or managed differently the first time? And this is a patient of mine who actually has not had a recurrence, thankfully, but another example of a foramen magnum meningioma you can see here, and really compressing the brainstem. Took her to surgery because, of course, that's the treatment of choice, and how intricately associated it was with the lower cranial nerves, the vertebral artery. We achieved gross total resection. But is this really a benign tumor given the potential morbidity associated with that surgery? So in the last 10 years or so, we have really begun to understand the genomic landscape of meningiomas. The Gunnell lab, as well as others, have elucidated the genomics underlying about 80% of sporadic meningiomas with somatic driver mutations. So to give an overview, the vast majority of meningiomas, about 50%, have a mutation in NF2. And this can occur with or without loss of chromosome 22. As I'll discuss on the next slide, these tumors can also have mutations in a SWI/SNP transcription factor gene called SMARCB1, which can then also lead to meningioma, and I'll talk about that in a little more detail. The second most common group of meningioma driver mutations falls under a gene that had not been previously described in neoplasia before, which is TRAF7. TRAF7 mutations can occur alone to drive meningioma formation, or they can co-occur with a mutation in KLF4, which is a recurrent mutation, and KLF4 is one of the 4 Yamanaka factors, or it can co-occur with a mutation in any of the molecules involving the PI3 kinase pathway, but the most common being AKT1. Hedgehog signaling has also been implicated, that pathway in meningioma formation with mutations in activating mutations in SMO or inactivating mutations in the tumor suppressor gene SUFU. And then more recently, we've seen mutations in POLR2A that can lead to meningioma formation. The one that's not on here is also another SWE/SNF transcription factor, SMARC-E1, which can be seen in clear cell and spinal, clear cell brain and spinal meningiomas. When I was a fellow at Memorial Sloan Kettering, I was really interested in understanding more aggressive meningiomas and their behavior. And so what we had found and published in JNS was that the tumors could arise, more aggressive tumors could arise either de novo as malignant or aggressive meningiomas, or they could progress from a low grade to a high grade, much like glioma. Marat's lab found out the scientific basis for this in the sense that these tumors are typically NF2 mutated. They usually can have a co-mutation, as I mentioned, in SMARCB1, or they have chromosomal instability. This can then lead to the de novo meningioma, atypical meningioma presentation, meaning that the tumor arises as a grade 2 atypical meningioma with this type of a molecular profile. That's as opposed to other types of tumors that can have NF2 mutation underlying. They can go on to acquire a TERT promoter mutation, and those tumors become atypical meningiomas by progressing from a low grade to a high grade. More recently, as I mentioned, we look to correlate the clinical characteristics of meningiomas with the subgroups. And so we performed molecular profiling of more than 3,000 meningioma samples and correlated the clinical data. And you can see all sorts of clinical data. And I'm going to share about 3 or 4 stories that we have published more recently, again, related to the clinical aspects. So in the 2013 Science paper, where we first described the meningioma subgroups, we also characterized the locations, the intracranial locations. And we since updated this in our JNS publication. And this is something that I find incredibly useful in my own practice. So NF2 mutated tumors, typically, when I think of those, they're more along the convexities of the head, of the skull, and there's a laterality gradient. So when and if they occur along the skull base, they tend to occur more laterally than medially. When they co-occur with SMARCB1 mutations, then the NF2 mutated tumors will be anterior to the coronal suture. When they're NF2 mutated typically alone, they'll be more posterior to the coronal suture. Along with SMARCB1 mutation, they'll tend to be more medially located as opposed to laterally. So there's something with SMARCB1 that alters the behavior and the location of where these tumors arise. For the TRAF7 mutated tumors and the co-mutated tumors, those are typically along the sphenoid wing, and that's something I'll get to in the next few slides after this. But those really do span the middle fossa and along the sphenoid wing. Hedgehog is very characteristic for midline and the olfactory groove. This makes sense given the fact that that pathway and the dysfunction of that pathway is implicated in holoprosencephaly. And then POLR2A, which we more recently described in this JNS paper, those tumors, mutated tumors, tend to arise in the sella. They extend down along the clivus, and then usually they can be seen in the CP angle. And of course, there's 20% of meningiomas that we do not understand the underlying somatic mutations for, the sporadic meningiomas. So from this JNS large study, the summary of some of the relevant findings in addition, NF2 mutant tumors, typically more common in males. They're really the largest tumors that we see, along with the hedgehog signaling molecule mutant tumors as well. They present later than others, and interestingly, they're more likely to undergo preoperative radiations. NF2 and SMARCB1 mutations are more common in higher grade with elevated proliferative index. That'll become a little bit relevant as I discuss later in my talk. KLF4 mutant tumors, more common in females. This has been established by us and others that it's associated with secretory histology, increased edema. and they typically present later than others as well. Polar 2A mutant tumors, these in our cohorts in our studies seem to be really the most benign in terms of their behavior and their pathology. They have the least amount of edema. They present the earliest, interestingly, likely because of their cellular location or along with the cranial nerves. And they're all WHO grade 1. Something that I became more interested in recently was understanding sphenoid wing meningiomas a little bit better, and specifically the bony involvement that we frequently see with sphenoid wing meningiomas. And so you can see here in the top, so there's a sphenoid wing meningioma, and then that hyperostosis and that invasion of that bone, and really what is the biology that's underlying that. And then here, down here, you can see these sphenoorbital tumors that have this really impressive hyperostosis and bowing into the orbit. So what does the biology suggest here? We looked at 64 patients who had sphenoid wing meningiomas, similar to this patient of mine here, with tumors that underwent whole exome sequencing. And the standard approach that I usually use on these patients are a pterional craniotomy, really aggressive drilling down of the sphenoid wing. And then in circumstances that we need orbital reconstruction, I enlist some of my colleagues who I had shown earlier. And you can see that a lot of times these patients present with proptosis, and this is 1 day after surgery, which is pretty remarkable that it can be corrected so beautifully, so quickly. What we did was characterize the sphenoid wing bone involvement, and what we used was the contralateral sphenoid wing in the same patient as a control for comparison. And we felt that this was a really simple way that could be easily translated to the clinic. This work has been accepted for publication in Journal of Neuro-Oncology, so should be out in the next few months. The type 1 is no bone involvement, and so you see here with the sphenoid wing meningioma, when you look at the CT and the MRI, the ipsilateral sphenoid wing looks pretty much like the contralateral. Type 2 is hyperostosis only, again, sphenoid wing intracranially meningioma, but then it's associated with just a little bit of a thickening of that sphenoid wing bone. Whereas opposed to type 3, which has frank tumor invasion, here, similar to that sphenoid wing meningioma intracranial, that soft tissue, we're seeing that enhancement within the bone. And then there's type 4 that has a combination of the two, which has an invasion of the frank tumor as well as the hyperostosis. And then as a separate category, the sphenoorbital meningiomas, which again characterized by that real bowing into the orbit. So similar to our prior work, we found that most sphenoid wing meningiomas harbored a TRAF7 mutation. That was the most common, and interestingly followed by NF2 mutation. And about 3/4 of sphenoid wing meningiomas do have bone involvement. When we looked at correlations between bone involvement and other patient and tumor characteristics, we found that tumors with invasion were more likely to be higher grade. They were larger, also compared to tumors without frank invasion. And sphenoorbital meningiomas were found in about 14% of these patients with bone involvement. Interestingly, the vast majority of those were hyperostosis only, whereas one was only in invasion of frank tumor, or soft tissue, I should say, with hyperostosis. These sphenoorbital meningiomas were exclusively seen in women. And not surprisingly, the patients typically presented with proptosis, like the lady I showed. When we looked at the genomic subgroups in bone invasion, we found that NF2 mutant sphenoid wing meningiomas were more likely to be associated with bone invasion, older age at surgery, and larger tumor volume. And you can see here, this is an example of an NF2 mutant meningioma, the frank meningioma tissue that's invaded in the bone that you can see there. Whereas TRAF7 mutant tumors were more likely to have hyperostosis only and a smaller tumor volume. And this is an example of a TRAF7 mutant tumor, where again, you're just seeing more of the bony overgrowth. When we looked at the ROC curve for predicting NF2 and TRAF7 mutations, we found that tumors with invasion were nearly 30 times more likely to harbor an NF2 mutation, whereas those with hyperostosis we see in B only were over 4 times more likely to have a TREF7 mutation. And so what we concluded was that tumor invasion correlates with NF2 mutation and higher grade meningiomas. And so the way that I think about this is that when I see a tumor, a sphenoid wing meningioma, and there's frank invasion of the sphenoid bone, it's really important, and particularly at the time of surgery, because we don't rely on the frozen to help guide our surgeries, to have as extensive a resection as possible, particularly because you could be dealing with a higher grade tumor. Hyperostosis is something we're working to understand a little bit better in the lab currently, and particularly the relationship with TREF7. The significance remains a little bit less clear, although I'll talk to that a little bit later in my talk, but still aggressive surgery is important, particularly for the bony decompression, for the associated ocular and orbital abnormalities that come with it. Switching gears to another story that we have worked on with regards to clinical correlations in genomics, of course, seizures was something that has always been fascinating to me with meningiomas. There's a relative high prevalence of seizure with meningioma, which is not as intuitive, given that these tumors are extraaxial. So we sought to understand whether there was something related to the genomic subgroups. We reviewed clinical and whole exome sequencing data of our patients, about 400 patients who were treated at Yale. About 17% of our patients presented with preoperative seizures. And in univariate analysis, we found that higher grade atypical histology, elevated Ki67, non-skull-based location, edema, brain invasion were all associated with seizures. We also found that these were more commonly seen in NF2 mutant tumors. When we did multivariate analysis, we found that edema and atypical histology were associated with preoperative seizures significantly, and NF2 mutations approached significance. When we sought to understand this a little bit better with mediation analysis, and what we found, not surprisingly, was that the NF2 mutation itself is not sufficient to drive seizure occurrence, but rather, and I apologize, this was published in JNS, and for some reason we should have had our p-value there, but what was significantly associated was the NF2 mutation with atypical histology, and this is what mediated the relationship between NF2 subgroup and preoperative seizures. And so it was mediated through the higher grade and the edema associated with the higher grade. When we looked at postoperative seizures, seizure freedom was achieved in 83%. Irrespective of extent of resection, we found that postoperative seizure patients were more likely also to have edema, recurrent tumors, and post-op radiations. And interestingly, the seizures occurred actually before the postoperative radiation, so it didn't seem to be related. I typically use prophylactic empiric anti-epileptic use in my patients, and we found that really had no prevention of postoperative seizures, similar to other reports in the literature. When we looked at progression-free survival, you can see on the left, A is looking at preoperative seizures. Patients who presented with preoperative seizures had significantly worse progression-free survival compared to those without. While on the right are postoperative seizures, there was no progression-free survival difference. And so what we found was that patients with meningiomas who present with seizures may indeed have a more aggressive meningioma, maybe higher grade, and maybe NF2 in terms of the molecular subgroup. And these patients seem to have a decreased progression-free survival. They seem to do worse overall. And so the way that I see this as well is that a patient who presents with seizure, you might want to be more aggressive in terms of how that patient is managed. And more work, of course, we need to do in terms of understanding the connection with NF2. Finally, in the last story that I'll discuss that we recently published in Neuro-Oncology, this was our first study, or the first study, I should say, to identify the molecular subgroup as an independent predictor of recurrence, along with grade and prior recurrence. We looked at outcome data for about 500 meningiomas, and similar to previous reports, we had enrichment of non-NF2 cases. And so really the distribution that we would expect based on the driver mutations we had in this cohort. Length of surveillance was 54 months, and we found that our overall rate of recurrence at 2 years was 12% across everything. Looking more specifically for low grade, the overall rate of recurrence was 7% and about 33% for higher grade tumors. What we found here for the first time was that 4 subgroups had appreciable rates of uncensored recurrence at 2 years. And so mutations in NF2, TRAF7, and molecules involving the hedgehog and PI3 kinase signaling pathways appeared to be more aggressive in the sense that they had higher rates of recurrence. The remaining 3 subgroups, KLF4, POLR2A, and SMARCB1, had only 1 recurrence amongst those groups. Interestingly, SMARCB1 stuck out to us because we had previously defined it as a pathway to more aggressive meningioma. So we were a little bit unclear why that didn't come out in the higher risk of recurrence. In further analysis, what we found were all SMARCB1 mutated meningiomas underwent gross total resection. So there seemed to be a relationship involving the extent of resection in SMARCB1, that it may indeed be part of a more aggressive meningioma pathway, but extent of resection could really help with that. And so what we found for these 4 more aggressive subgroups that we defined, they had a 22 times higher rate of recurrence risk. And amongst low-grade samples, this was 17 times higher risk of recurrence. When we sought to understand these aggressive subtypes further, we found at 60 months, hedgehog, NF2, and TRAF7 mutated meningiomas continued to exhibit elevated risks of recurrence. Interestingly, and as you can see in this table over here, most of the PI3 kinase mutated tumors recurred within the first 24 months. And so they had a higher risk of recurrence, but theirs was an earlier risk of recurrence. When we looked at univariate analysis for progression-free survival, we found significant associations negatively with progression-free survival, with higher grade, non-midline location, atypical histology, elevated proliferative index, previous recurrence, and then protective were gross total resection and female gender. What we found here were that NF2 mutant meningiomas were negatively associated with progression-free survival, while KLF4 meningiomas were protective, it seemed. Again, similar to our seizure story that I presented before, when we looked at multivariate analysis, we found that NF2 came out, and what we concluded was that NF2 mutation itself, very similar to seizure, is not enough to drive the recurrence and have its impact on progression-free survival, but rather it is dependent on more aggressive features such as grade and histology, atypical histology. So going back to the initial patient that I presented with this convexity meningioma who has seizure, could this have been better predicted and managed differently? And so this is an example of our integrated diagnosis. All of our brain tumors undergo whole exome sequencing at Yale, and this is a typical report that we receive. And so here we see that he has a clinical histologic diagnosis of atypical meningioma. Initially, he had been diagnosed with a grade 1 meningioma by report. When we look at the whole exome sequencing data, not surprisingly, convexity location, had seizure, we see an NF2 mutation, and we see the chromosomal instability that's associated, and of course, chromosome 1p deletion, chromosome 22 deletion. What we didn't find is a TERT promoter mutation. And so taken together with what we know, this was likely a de novo atypical meningioma, and he was likely in a atypical meningioma when he had first presented to the outside hospital years ago. And so to answer that question, I would say that, yeah, this could have been managed differently, because in our hands, we would typically gross totally resect the atypical meningioma, and then we would proceed with radiation. This is another patient, actually, Dr. Pietmeyer's patient, who I had assisted with the surgery a few years back in 2017, large sphenoid wing meningioma. This is in 2017, 70-year-old woman who presented with decreased vision in her left eye. We decided to leave a little bit of tumor in her sala. This was her post-op scan in 2018. And a few months later on her scan, you see recurrence. And so pretty impressive recurrence, and even to the contralateral side. At this point, she underwent radiation, and you can see even despite the radiation, she had further growth. And actually, this is not her most recent scan. I did an update. She's since had surgery again. She's since has had further radiation. She's been enrolled on a clinical trial. And so when we look, and despite the multiple surgeries that she's had, this came out to still be what we call a benign WHO grade 1 meningioma. And so that is the histology that we see here. However, when we look at the whole exome sequencing, we see the AKT1 mutation. And so similar to what we have found, or what we would predict in the neuro-oncology paper, is that these tumors that have mutations within the PI3 kinase signaling pathway tend to recur sooner after surgery. This is a similar patient, and this is her imaging when she presented to me in 2020 with this sphenoid wing meningioma. As you can see, really a quite vascular tumor. But she had initially presented back in 2006. She underwent resection multiple times, radiation multiple times, and failed all of that treatment, and enlisted in the clinical trial with Pembro at MGH with Priscilla Brastianos in 2019. When she failed, Priscilla sent her to me for resection. And you can see there, a nice resection. She actually improved quite significantly clinically, post-operatively. And yet again, after all of these years, histologically, the tumor remained WHO grade 1. However, you can see again, the AKT1 mutation is underlying, and she has chromosomal instability. And so again, this we would predict that this would be a more aggressive tumor, not based on histology, but based on whole exome sequencing. And then this is a more recent patient of mine, actually with multiple meningiomas, which is a whole other story that that we're working on in the midst of writing up and publishing. But this is a patient who had some edema with this perisylvian sphenoid wing on the left. So I ended up taking out that tumor. This is him, his post-op MRI. That's actually his anatomy after the resection. And again, grade 1. Here we see he has TRAF7 AKT1 co-mutated. There's no chromosomal abnormalities that were seen. But this raises the question, what to do with him? In the sense that, is this someone who we would consider following closer, of course, given his mutation? Is this someone we would even consider giving upfront radiation? And I don't think we're quite there yet, but this is certainly someone that we keep a closer eye on. And so I lead and direct the multidisciplinary tumor board here at Yale. We also have our precision brain tumor board, which is, it follows and piggybacks onto our multidisciplinary brain tumor board. And each patient, with every brain tumor we discuss, and particularly with meningioma and even the grade 1s, we really do rely quite a bit on the whole exome sequencing to help guide what we recommend and how we follow patients and whether or not we use radiation more aggressively. So in summary, in my opinion, I really think there is no such thing as a benign meningioma. I think we can get fooled pretty easily. And we really can't just rely on the histology. And so for us, we use the integrated diagnosis, which has been really helpful, but of course, more work needs to be done in terms of understanding the genomics and epigenomics, and more trials are certainly needed. In particular, in my mind, with understanding the role of radiation with these more aggressive low-grade meningiomas. I just wanted to acknowledge all the patients who contributed, of course, to these studies, people in Murat's lab, people in my lab, and then this is my clinical staff, my 2 nurse practitioners and my 2 nurses who are everything as part of our primary brain tumor surgery program. And I will conclude with my 2 favorite guys. So thank you so much.
Beautiful work, Jennifer. I'm getting so many compliments and so many text messages and right here in the chat as well. If it's okay with you, I know that they put your schedule. We have the schedule right now. We'll just take a few minutes for a few questions from the audience. You know, Bob, you dealt with a lot of these. You've been talking about these meningiomas for a number of years, you know, and any thoughts, questions from your side, please?
It's fascinating to see his tremendous work, the molecular correlation of so many years of clinical observations. And this is a beautiful example of how molecular data may help us to better manage our patients. Tremendous work. Thank you.
Thank you so much.
Thank you, Bob. Thank you. One of the things, and if you, what was that, Jennifer?
Dr. Wharen has a beautiful sunrise. I noticed as it was happening.
Yes.
It's finally coming up.
He's been up since like 3 in the morning his time. So waiting for your talk. Very excited. If you can raise your hands, from the audience, Dr. Lobos, who is going to be talking about NF2, as you know, he's visiting from UAV. We've been working with him in the neuro-oncology. Dr. Rosenfeld, Dr. Barrett, and Dr. Sherman have been working in his recruitment, and he's interested in talking further. Obviously, he's a junior faculty with great ideas, of course, about tissue and collection. Maybe I can kick off by asking one question. The issue of, and then I see Dr. Vargas from Bucaramanga in Colombia, who may has a question. The issue of edema, Jennifer, is always a complex one, all right? And small little tumors, tons of edema, large tumors, no edema. Any correlation, any ways to predict that? Sometimes we think it may be venous, maybe vascular, congestion. Is it more than that? I guess that's really the question that I'd like to formulate. If you have any insight into that.
So I think that, that always strikes me as well. And I think we get fooled regardless. From the genomics, I would say that typically if we're dealing with a smaller tumor that's along the sphenoid wing that's associated with a ton of edema, then likely I would think that it's going to be KLF4 mutation, because that fits with what we found clinically. And usually it does turn out to be. Regardless, though, we remove the tumor because of all the edema, and so that's the treatment for that. The bigger ones, I find, when they're bigger and they're associated with edema, they're usually atypical and they're usually NF2 mutated. So I think regardless, they usually come out just because of the edema that's associated.
Amazing. Good. Thank you. Gabriel, we go to you and then to Dr. Garcia, to Diogo. Go ahead, Gabriel.
Thank you. Thank you very much for that.
I think you just muted yourself, Gabriel. I think you might have pressed the button right there.
Yes,
there you go.
Yes. We are located in Bucaramanga, Colombia, and we're not able to do all genomics studies tumor by tumor. It's so expensive for us, $50,000 to do that. So I saw you told that maybe we can choose some of the studies or molecular findings depending of the location.
Mm-hmm.
In practice, you do that, or you do all the genomic studies in every single meningioma? I agree with you, it's not benign, it's not that easy. When we see that young neurosurgeon, I don't know, say meningioma, just took it and that's it. It's not like that. I agree with you. It's something more complex even then. So
right.
What do you think about how we can say to the pathologist, please do this to this tumor or this kind of a study?
So I think that, and that's why I think that, working and identifying the genes is so important, obviously, but the clinical correlations is so important, because not everybody, as you say, is in a position to do whole exome sequencing on every tumor. And even more so than that, like we saw with that one case of the convexity meningioma, those oftentimes are handled at community hospitals. And community hospitals might not have the same expertise in neuropathology as we saw, where, it's diagnosed as a grade 1 rather than grade 2. And so that was missed. And so I think that that's why I try to get these publications out there and giving talks such as this, because I think it can be really helpful for the little tricks that we can use. And so what I typically rely on are the location. the location is really very helpful, I think, in predicting what the underlying genomics is going to be. The ones that I am very interested in the genomics are typically the more posterior ones by the torcula. As we go back towards the torcula along the convexity or even parafalcine, those typically are the really nasty ones. And so those are the ones that even when I get told that they're grade 1, I really am interested in those, the underlying genomics. And specifically there, I'm interested in what the chromosomal abnormalities are and the genomic instability, because that will push me at times to treat it more aggressively with following up with radiation. So those I'm usually interested in. The sphenoid wing ones, you know, that whole sphenoid wing study was done because I just started to notice that the ones that had all this bony invasion seemed to be TRAF7 mutated, whereas the ones that had frank tumors seemed to be NF2 mutated. So I think that has held really true. And so that I don't think you need to waste, you know, genomics on, because I think that will give you a big clue as to what's underlying. And the other one I wouldn't waste the genomic testing on are the olfactory groove ones, because those are always going to be hedgehog signaling pathway, and SMO and SUFU are usually the most common. Those will have a higher risk of recurrence. And we always often wonder, is it because of some hyperostosis at the skull base or some tumor that's left and that sort of thing. So that I don't think you need to waste the funds on either.
Thank you very much.
Beautiful. Thank you, Gabriel. Diogo, take it away, please.
Dr. Moliterno, thank you for the amazing talk. I just wanted to ask you something. Being able to do whole exome sequencing on all the meningiomas is actually quite fantastic. I mean, you're accumulating a wealth of knowledge that I think will be quite interesting. But have you ever considered also including DNA methylation status, as a lot of meningiomas won't have any changes at the level of the genome, but will actually have a lot of changes when it comes to epigenetics, and that has proved to have prognostic and therapeutic implications also.
Absolutely. And so I have followed that work quite a bit, and Galera, who's done quite a bit of that, is a friend of mine. And that's not something that we use here at Yale, and we have not incorporated it. And I don't have a great reason as to why, to be honest with you. But I do think that the answer lies in all of the above. So I think the genomic and epigenomic certainly have a huge impact in terms of the management of patients, for sure.
Thank you.
Beautiful, beautiful. And then to continue, one of the comments that I was watching and between the chat and this right here, Jennifer, is that even some of us stopped calling the meningiomas benign. We began to call them cancers versus non-cancers, but your talk is beginning to make me rethink even that nomenclature, because even calling them non-cancers sounds to me that, given the findings that you have so far, is also incorrect, because they are, in some ways, are cancerous tumors. I mean, it's and you see, you show some of those beautiful cases, you know, that we saw that you presented, obviously. So what's your overall, when you talk to a patient, I guess, for us to counsel the patients, you know, what do you think would be the ideal world for us to begin to manage these cases in regards to the sequencing and also the discussion with them as we approach these tumors?
No, I think that's a really excellent point. And I have changed the way that I talk with patients with meningiomas. And so a lot of times I will use the location to help guide how I start the conversation. And I usually talk about them because, of course, the patient, when they get referred to us, they've already seen other people. So they've been told that they have a benign tumor, they have a non-cancerous tumor, and that sort of thing. And so, although I just, you know, I say that the vast majority are slow growing and are grade 1, and I describe what that means, but that they can come back. And, you know, I find this all the time. Patients are always, you know, asking what cancer and not cancer, and what is really cancer. It's the concern about a tumor that can grow back, that can be difficult to treat, that there's no chemotherapy for currently, And meningioma certainly fits all of that. Having said that, the majority of them, can be managed with surgery, and patients move on, and that's okay. They should still be followed. But I am very careful in how I talk with them, for sure.
Quite impressed. I mean, I think that as I'm listening to your talk, there are in a spectrum. You're right. There are probably some of them, as you said, that they will get management surgery alone. They're never going to have to deal. They're going to be probably in the spectrum of the benign type of lesions. But then there's going to be a whole spectrum, depending on these mutations that you're beginning to define, as to whether or not this is going to be something they're going to have to deal with this problem forever, more surgery, more radiation, a combination of both. And I think that the things that you're doing are beginning, the location, the sequencing that you're doing, the molecular markers are allowing us to do that. A beautiful work, Jennifer. We're so impressed. You have no idea how many comments I have gotten actually, about this. So I wanted to thank you. I think people got a sense of how extraordinarily accomplished you are, how extraordinarily humble you are. And I remember the day I came, what was it, 2 years ago, I was there at Yale visiting with Andre, and I requested just to say hi to you, and it was a surgical day for you. And I remember your assistants, they got me into your office, and they gave me a cup of coffee, and then you came in between surgeries, and I was just so impressed with not only the way you conduct yourself, you're very, Dr. Mesquia said, thorough and thoughtful. That's what he said, told me, and Dr. Mesquia was the former chair of neurologist. A few months ago, he stepped down, and he's an amazingly accomplished clinician scientist who's done a lot of work in the CREST studies. So he's very, very, very good judge of character. So we thank you immensely for your work.
Thank you so much for the opportunity to be here. And like I said, I plan to invite myself to person. So I'll see you all up anyway.
Yes, good. Well, you have already, we saw Andres put your schedule right there from 8 to 9. We're going to have the fellows and the residents. And then at 9, you're going to be meeting with Dr. Chen, Dr. Yachano, residency director and associate research director, and Dr. Boriyama, Nat Meyer and Fox are going to join there. We're all running around. They want to say hi to you. And then you're going to meet in at 9:30 with Dr. Guerrero Casares in his laboratory. And then at 10 with Dr. Sarabia Estrada and Dr. Schiaparelli. You saw some of their work that we shown they're interested in talking with you. And then I'll wrap it up at 10:30, and hopefully get you back to your clinical activities and your surgery and everything. We thank you immensely. Bob, thank you, for being here with us.
Well, thank you, Dr. Moliterno. That was excellent work. Thanks.
Beautiful. We continue the tradition, Bob, with amazing speakers, obviously. And last year it caught us all by surprise because we were ready for some of these lectures, and it was just the year went so fast, and we're still not out of it. I mean, as Bob said at the beginning, he thanked everybody for their work in the COVID, and we're not out of the woods yet. We continue to hear in the news that things are continuing to become an issue. So everybody take care of themselves, and Jennifer, we'll see you later. Continue. I think that you stay in this link, if I remember correctly.
No,
it's another link. Yeah.
Oh, it's another link, Andres?
Yeah.
And can you make sure that Dr. Moliterno has it so that way we're ready to rock and roll?
Yeah, I did send it this morning, and it's on the itinerary PDF as well.
Okay. Double check. If there's any issues, Jennifer, just text me and I'll link it to you right now.
Thank you so much.
Have a great day, everybody. Thank you. Bye-bye.
Yes.